In this session, we'll discuss management of an avulsed tooth and fractured front teeth. How can we save a front tooth which has been knocked out from the patient's mouth and is intact? How do we put it back, and how do we place a dental splint and fix it to the patient's mouth? Fractured teeth are quite common accident to occur on an expedition, and how we deal with it depends on what is the degree of fracture and what materials we have with us. So we now have a situation where the front tooth has been knocked out and we have to try to save this intact front tooth. So therefore, what we have here is the front tooth in blood. What we are going to use is a dental splint. So the dental splint which we use is essentially the nasal clip of a face mask. So we cut our face mask, take it out, and this is an excellent material, easy to adapt and easy to use. So the first thing to do is, it takes 8 minutes after the tooth has been knocked out for a blood clot to form. So the first thing we have to do is to take the blood clot out. When we take the blood clot out, we stimulate the bleeding from the surrounding soft tissues to help in the take-up of the reimplanted tooth. Local anesthesia is preferable but not essential. What is essential is the time factor for these patients. When we take our blood clot out, it's a combination of using the tweezer gently and a gentle rinsing in that area. We avoid scraping the side of the bony socket when taking the blood clot out of that area. Next, we grip the tooth. We only hold the tooth by the crown. We do not touch the root. It is important that we do not touch or do not handle the root, or as little as possible, because there are living cells on the root surface which will help in the take-up of the tooth once it's reimplanted into the patient's mouth. So we do not touch the root surface at all. However, should the need arise that we have to get rid of the visible debris, then we rinse the tooth with normal saline, clean, cool water or milk, not more than 10 seconds, just to get rid of any visible debris from the surface of the root. Then we check the adjacent teeth, because it is important that we push the tooth the correct way round. It would be rather embarrassing if it is placed the wrong way round. Once we pushed the tooth in, we take our tooth, we push it in with firm digital pressure till it is, so if this is your tooth, we pushed it in and we push it in till it is in level with the adjacent teeth. Okay? Once you've done that, we tell the patient to bite on a plastic biro, wooden spatula, anything like that for up to 8 minutes. This helps in the formation of a blood clot around the tooth. Once this blood clot forms, the oral environment is more conducive for us to work in. There's decreased salivation, decreased blood, improved visibility of that area. Sometimes it might happen that the tooth is actually not fully knocked out. It's fractured against the bone, in which case you might have to put firm finger pressure to realign the tooth before placing a dental splint. So this is the time when the patient is biting on a wooden spatula or a plastic biro for 8 minutes for a blood clot to form. This is the time we use to fashion our splint. So we take our nasal clip from the face mask and we cut it to the required length. The required length is 1 to 2 teeth longer than the naughty tooth. What do you do with the ends of the splint? We try to tuck the ends of the splint between the adjacent teeth. Where is the splint placed? Midpoint between the gum line to the top of the tooth, so the mid portion of the teeth. It should be 1 to 2 teeth longer than the re-implanted tooth. Now, if you don't have a splint, what can you use? You can use a steri strip, you can use wound glue, you can use a steri strip with a wound glue. Safety pins are really hard, or paper clips are really hard to use for these patients because they are round and they don't grip well. they're difficult to adapt across the surfaces of the teeth. Once you put your splint on, what we do is we use our adhesive filling material. This is the powder and liquid filling material which we described, which is also known as the glass ionomer filling material. So we took 2 scoops of powder, 2 drops of liquid, 1 minute to mix it with, 1 minute to use it with. When you mix it, it is like a chewing gum consistency. So we take our scoops of powder, we put it on a mixing pad, we take our liquid, and we'll read our instruction manual, what liquid it is and how much do we take it with. So in some, as I said, there's liquid in the liquid bottles. In some, it is a measuring bottle where you use plain water. So we take the required liquid, we pop it onto a mixing pad. If we don't have a mixing pad, we can use glass or plastic, but not paper. Then we take our spatula and we have 1 minute to mix it with. As we mix it for 1 minute into a chewing gum consistency, you can see it is a big thick chewing gum consistency, and this is what we use. So we take a big blob of it and put it over the splint onto the tooth, a sufficient quantity of it, and we do that on all the teeth including the reimplanted tooth, because we need sufficient amount of it to give it enough strength to hold the splint onto the surface of the tooth, and that is very important. So once we have done that, then the patient should be dentivac as soon as possible. If the patient declines, write it in the note because it will affect his prognosis. What will happen is once he goes to the dentist will do a root canal treatment and then take out the splint after 2 to 4 weeks. Now the critical bit is if you have placed the tooth in and reimplanted it in the patient's mouth and you've done it within the first hour, the success rate is 80%. After the first hour, the success rate drops to 20%. So it's very important. Time is a critical factor for these patients. Now, if the patient is unwilling for you to do this and has to be transported to a local dental hospital or a primary healthcare facility, where to store his tooth? His tooth could be stored either in the floor of his mouth or onto the cheek side in his mouth. If he is unwilling to do that, the patient can spit into a bowl of water and then you can the patient can spit into a bowl and you store the tooth in the patient's saliva, not water. The tooth is stored in the patient's own saliva. That is another good transport medium. If that is not possible, then you may think of milk as a means of transporting the tooth. What do you do if you have the patient who refuses to be dentivac till the end of the expedition? Till the end of the expedition, you suggest a soft diet. You suggest scrupulous oral hygiene, but gently where the splint has been placed. If you have coccygeal mouthwash or coccygeal gel, it's twice a day for a week. Suggest non-steroidal anti-inflammatories and broad-spectrum antibiotics for 7 days and check the tetanus booster situation. Now, what if you do not have glass ionomer or the adhesive filling material? What if you do not have a nasal clip of a face mask? Can you use anything else as a splint? You can use Compeed as an adhesive splint. You can use other types of splints, like you can use a blue tack, soft cheese, soft wax from the outside of a cheese, duly clean. Thermoplastic beads, Stum adhesive paste is an excellent splint if you can get hold of it. Or a foil splint, but all these are not very mechanically retentive and they will last only for a short periods of time. You can try a suture splint, which is rather fiddly to use because when you tie it, you'd have to use the thickest black silk suture you can find. And when you tie it, you have to be careful because as you tie it, this tooth will pop out as you tighten the splint up. If it is required only for a short period of time and the primary dental healthcare facility is very close by, you can just reimplant the tooth, tell the patient to bite on a piece of gauze which will hold the tooth in place and send him off immediately to the nearest dental department. Pediatric or children's teeth or deciduous teeth are not re-implanted. You can just throw them aside or place them for records. Fractured teeth are also not possible to reimplant because the uptake is quite poor. So in the next discussion on our session, we will discuss fractured teeth and what we can do. Teeth fracture quite often on expeditions, and it is really good to know how to deal with them. It is one of the most common accidents that take place on an expedition. So if you have a chipped front tooth, what can you do? It all depends on how big or deep the chip is and what dental materials you have at hand and how far away is the dentist. So what are the likely filling materials you might have in your kit? You could have the pre-mixed ones like Cavit. Fortunately, if you could have the adhesive filling materials like glass ionomer or both of these. You may have a sedative paste with you or eugenol or clove oil with you. Now, if the fracture is just going through the enamel and it is a very small chip, so it's just a small chip going through the enamel, ask the patient if there's any problems. If there's no problem, you don't have to do anything. However, if it is sharp, you can use a nail file to gently smoothen the sharp edge. What if the fracture is deeper and it is going through the enamel and the dentine? It's a bigger fracture and the second layer of the tooth is exposed. Your objective for this patient is to control the patient's sensitivity and to prevent the bugs from his mouth going through the spongy part of the dentine in through the tooth to infect his pulp. If the dentist is close by, keep the fractured tooth section wet and send him off to the dentist. The dentist could possibly stick this broken piece of tooth back onto the tooth surface. If you have an adhesive filling material, this is an excellent intraoral bandage. You can just plop it across the exposed areas of the teeth. You'll seal the tooth up, control the sensitivity, and prevent the bugs from getting sucked into the tooth surface. If you don't have that, and if you have a wound glue like Dermabond, you can use it in a similar way to seal the spongy parts of the tooth, preventing the bugs from getting in and controlling the sensitivity. If you have the sticky fluoride varnish, you can put that on. You can make a temporary dressing with a temporary filling material. Both of these are not retentive, but you will have to work with what you have. If you don't have that, you can just use some anti-sensitive toothpaste and leave it on the tooth surface. Repeat this procedure at least 4 times a day. When you're doing an intraoral adhesive bandage using your intraoral filling materials at a high altitude, you must remember that materials or medicines used to prevent cracked lips or Vaseline-based materials, if they contact the tooth, then your adhesive filling material will not stick to the tooth. So you'll have to clean the tooth surfaces either with an alcohol-based cleaner or washing up liquid to get rid of any of the oils which are present on the tooth surface, allowing a filling material to stick to the tooth surface. If the patient breathes through the nose, that will also help because breathing through the mouth will create condensation and that will prevent the filling material from sticking onto the tooth surface. We do not recommend superglue be used on the tooth surface. The reason is that they are short chain cyanoacrylates that degrade and release toxic products. Also, when setting, they give off heat that could irritate the tooth. If there is cotton present around, the cellulose in the cotton interacts with the superglue and may catch on fire. So we do not recommend superglue being used in the mouth, though there are lots of anecdotal data where it has been used, but we do not recommend it. What happens if the chip or a fracture is going through the third layer, which is the pulp? But you can see that it's exposed only a little bit. So when you have a very small exposure of the nerve of the tooth, it is not big, it is less than a millimeter, it's a pinhead exposure. How do we treat this patient? So for this patient, the objective would be to cover the tooth, to sedate the tooth, to prevent it getting further irritated, to protect the tooth from sensitivity, and to prevent any bugs from getting into the tooth surface. So therefore, for this patient, the gold standard is by using a calcium hydroxide paste known as Dical. It is rarely ever present in expedition dental kits. What is present generally is glass ionomer, which is your adhesive intraoral dressing. But we know that this is acidic, and we do not want the acidic filling material to come in contact with the nerve because it will irritate the nerve. So we could protect this little bit of nerve by using Ledamix paste if we have it, which is this mild antiseptic steroid paste, just a little bit, just a drop onto the exposed part of the nerve, and cover the rest of it with your sticky intraoral dressing made by your adhesive glass ionomer filling material. If you don't have that, and if you have the non-adhesive powder and liquid based one which has clove oil extract mixed in it, though it will have no adhesive properties, you can make a good dressing to cover this whole tooth surface, allow a bit of it to go in between the teeth to get a bit more mechanical retention to provide you with a fairly okay intraoral bandage. However, the prognosis of this intraoral bandage will be poor because there is no chemical retention with the tooth surface. Again, if you have the premix soft variety, you can do something similar. Again, because it does not have any chemical retentive properties, it may not last very long, but at least it will not irritate the tooth surface and will protect it to a certain extent from sensitivity and bugs as long as it stays there. You can push it in between the adjacent teeth to give it as much retention as possible. What if you have both of these? You can take a little bit of this, just a small bit of it. We know it's non-irritating, but it doesn't stick to the tooth. We plop it just onto the exposed nerve of the tooth, just a little bit of it. And then we cover the rest with this slightly more irritated acidic but adhesive filling material. So it's a sandwich. So this one is non-adhesive but is not irritating and will cover the exposed nerve. This one is adhesive but irritating and will form a bandage around it. So first this one goes in to cover the exposed nerve, and that is covered by this adhesive filling material to hold it all together till the patient visits his dentist. You may just make a splint across the whole area. This is a splint made with a stoma adhesive paste. What if your fracture is a big one and has gone way through the pulp chamber? It's a big, deep fracture. Now this is really deep and the tooth is going to die. So it is only pain management and to stop bleeding for the patient, because the tooth will essentially die sooner rather than later. So how do we stop the bleeding? We can use a local anesthesia with adrenaline, or you can use hydrogen peroxide to place it on the exposed nerve chamber to stop the bleeding. And then you can put some sedative paste on it and cover it with an adhesive filling, cover it with a mixed eugenol based filling which will cool it down to a certain extent, or you can cover it with a temporary filling. This patient may need antibiotics, but depends on how much antibiotics you're carrying with you. If not, you can just wait and watch. If the tooth gets infected, shows signs and symptoms of swelling, pus discharge, then you can give him antibiotics, because antibiotic courses may be precious on an expedition and you want to use it only when you definitely have to. This tooth will gradually die, and then the dentist will do root canal treatment on that tooth and then build it up or extract the tooth. What if the root of the tooth is fractured? What can you do then? It all depends on the condition of the top part of the tooth. So if the top part is relatively non-mobile and or just mobility is there but only a little bit, you can just put your splint across like your nasal clip of a face mask and your adhesive filling material, and then send the patient off to the dentist. However, if it is very loose and there's the chances that the patient could aspirate it, inhale it, or it's preventing the patient from closing the mouth, you might, and if the patient cannot be tentivaced, you might be forced to just take out this loose top bit of the tooth, but let the roots remain behind, because it would be too complicated to deal with on an expedition, and there is less chance of it giving immediate problems at this particular stage. So you just remove the top part, loose of the top part of the tooth. In our next session, we will discuss simple dental extractions, and incision and drainage of a dental abscess. Thanks a lot.